make room for one more at these resource facilities, these large hospitals and healthcare systems, to accommodate that patient care that is needed immediately and must be done expeditiously in order to care for these very critical patients, and provide the care that they need, so that additional injury or harm does not occur. We instituted this policy effective the morning of, Wednesday morning this week. And we have had it in place. It has been very well received. It has worked very smoothly so far. It does not require. We've not required to place a great deal of a large volume of patients. And to date, we have only utilized it for the care of two patients throughout the state, one from Central Washington, one from Western Washington. But in both circumstances, both patients and hospitals received the resources that they need from large healthcare systems. And as a result, that care was able to be provided immediately, which is exactly what they needed. We will still, at the Washington Medical Coordination Center, utilize our typical strategies for the balance of the patients and patient requests that we receive, which can be 30, 35 requests in a 24-hour period. However, for that subset of the population that needs that immediate care, they're going to rise to the top and get that care as soon as possible, which is exactly what they need. I think the other thing that I would mention at this point is that many of the processes that are now in place for the as a result of the governor's proclamation, which involved things like census management, the assets that have been put into place with the National Guard, are now starting to see some benefit from those processes. And the hope would be that we will be able to stand back from this guaranteed acceptance protocol as soon as possible, and return to sort of normal operations. But what's important to recognize is that this process is in place, and through this commitment that our state's hospital and healthcare system has come together to support, we have sort of a safety net in place to provide that care when necessary. I may stop there.
Thank you, Mark. Great report. And to follow on my prior comments about the staffing ratios bill, this guaranteed acceptance protocol would not work if we had staffing ratios in place. We could not do it. And we, in fact, discussed it with our colleagues from California, and they said they could not operationalize that in their state. So it's that's the sort of inflexibility that bill would bring that could really harm our patients. Dr. Mint, let's hear from you about what Pierce County has been the kind of the leading edge of this wave. Love to hear what Multicare is seeing both in the west and the east sides of the state.
No, thanks, Cassie, and thanks for inviting me. Love to share Multicare's experience in this. I just, after listening to Mark, I only want to just call out he and his teams over there, along with a lot of partners, in regards to just our being very proud to be in Washington State and such a community of health. Multicare participates in this guaranteed acceptance program, and we understand the importance of it to continue to serve our communities. It is incredibly challenging times, as we all know. I'll go into some numbers in just a little bit, but again, I'm just really proud to be in a community, and professionally, I am proud to be part of these conversations, trying to best take care of our citizens in Washington State here. So our hospitals continue to be incredibly full. Unfortunately, we do not want to be on the leading edge of this particular metric, but Pierce County and even King County, South King County, especially in the last few weeks, has really, unfortunately, been amongst the highest rates in the state and even in the nation. Our prior peak, just to give you some numbers, our prior peak in the Puget Sound area of inpatient patients who were COVID positive was about 200 during the Delta peak. That was our peak prior to Omicron. Last week we hit 400 inpatients, double that of our prior peak. And again, the Delta peak was just one among many peaks that we've gone through, unfortunately, in these last 2 years. So we're down a little bit. I do also mirror what Cassie and Mark alluded to from an epi curve. Being the first up, hopefully this is a harbinger that we are starting to plateau off. This week, our patient down from that 400, we're down in the mid 300s now of inpatients, and that's been very that's been very helpful for us to be able to catch our breath and continue to offer care. But those patients are still around 37% of our hospital beds. So just to tell you how much of our capacity right now is being used for necessary care for COVID positive patients. 13 of our patients are on ventilators. And the sort of the good and the bad. The good news is that we're not seeing as many patients on ventilators as we have during prior variant waves. But because of the high number of patients, we're still seeing patients very ill with COVID-19. Our hospitals remain at very high capacity. I'll just call out Auburn Medical Center continues to be, at about 170% of capacity. Just to be clear, like all hospitals are above 100%, but some of our hospitals have been harder hit. But that also has been stabilized here. Our Mary Bridge Children's Hospital is also mirroring what we're seeing across the state, which is increasing pediatric care in the emergency department for COVID positive patients and an increased hospitalization rate. Our death rate in our hospitals, I'll only want to point out that vaccinations still matter a lot in regards to this. The current CDC terminology is that you're up to date if you've had all of your CDC recommended booster shots, initial vaccinations and booster shots according to their schedule. So I'll use that terminology. But in our deaths, we've been reviewing all of our deaths in the end of December and early January. And of those deaths that we've just recently reviewed, 20 of the 22 deaths were not vaccinated. And none of those deaths were up to date with their vaccinations. Overall, we're seeing patients who are up to date with vaccinations only represent 1% of our hospitalizations. So being up to date actually is very preventative. That's compared with over 20% in our community of patients who are up to date. Just shows that that is very protective of becoming sick enough to require hospital level care. So important for us to continue to get this message out to our communities. Understanding that that there still remains some pockets of vaccine hesitancy that hopefully we can continue to have meaningful conversations with. We're deferring. We continue to follow the governor's direction in regards to, and we've been doing this well before that, of delaying procedures. Now, we use the term sometimes elective procedures, but I know at this group we've talked often that abnormal finding on a mammogram or deferred a colonoscopy for preventive purposes can have significant negative consequences, both in regards to patients' health and well-being, in regards to patients' pain control for some procedures that are considered elective, and we continue to work with WISHA, the governor, and other stakeholders, just making sure that we can continue to, as quickly as we can, start to offer procedures back to our patients on medically necessary procedures that may not be immediately life-threatening, but definitely something that helps in patients' wellness and well-being. Amongst our pediatric populations, I only want to also call out that even though we are saying and we are observing that Omicron has less virulence in regards to patients requiring ventilators or dying from this, at least as we're observing now, COVID-19 also has unanticipated long-term consequences. Our pediatricians at our Mary Bridge Hospital were noticing an increased rate, and they first just observed this, but a recent MMWR publication confirms that it does appear that children under the age of 18 are having higher rates of type 1 and type 2 diabetes post COVID-19. So it still remains very important for public health initiatives to decrease opportunities for folks in the community to to become exposed to COVID-19. And we do want to still emphasize that a lot is unknown about COVID-19. It is not yet, an endemic infection that we have good expectations about what the risk benefits are for folks who get this disease. There are still things we're learning about long-term consequences. Cassie mentioned PPE. We continue to work to meet the governor's criteria in regards to conventional use of PPE, but it is challenging. Our supply chain leaders in our organization have really gone above and beyond, working really, really hard with WISHA and other partners to make sure that our staff and our patients, there's an evolving science in regards to what's the best protection. And I think that the CDC continues to work on this, and we hope that we continue to reflect the science and best practices of use of our personal protective equipment to protect our caregivers and our communities. I'll end with a little bit of just multiple partnerships that we are, again, very fortunate to be part of. We're working with our Department of Health and local health jurisdiction partners to equitably get out the newer medications that work against Omicron variant of COVID-19. Those include molnupiravir, Paxlovid, Sotrovimab, which is an intravenous monoclonal antibody, and Evusheld in a preventative manner. These drugs are still extremely limited supply, but it's been really fantastic working with the state and trying to make sure that we have an equitable way to get these to our highest risk patients in our community during the surge. Our partnerships with DOH and DOSH in relation to working on the rules and regs in regards to use of masks and other equipment. There's really two different ways that we use these. One is personal protective equipment for our healthcare workers, that is to protect healthcare workers from infectious or potentially infectious care for patients, but also for source control, given the way that Omicron especially has affected our healthcare workers, making sure that healthcare workers can come back to work safely. We use masks and other equipment as source control, and the evolving science of that. And we're really love working with our DOH, other healthcare systems, and other partners in making sure that we're doing this in a way that meets both our regulatory and safety intents, given this unprecedented surge. Lastly, our partnerships with the National Guard in regards to, and we're thankful for Governor Inslee and partnering with us in that. They're coming to, we're partnering in our Tacoma General site, and this is really, really helpful to help manage our patients through our emergency departments, going into our hospitals, so that we continue to maintain what Mark was mentioning, which is access to our communities to high acuity patients who need our care, especially the urgent emergent cases. And again, I'll end my testimony here, and or testimony. I say testimony. I'll end my media update here, and be open for questions later. Thank you so much.
Thanks, Dr. Bent, and thank you for. I didn't say this. I should have said it, that we are riding the coattails of Multicare and our 3M mask order. Multicare has opened the doors for us to 3M, so thank you very much for doing that on behalf of all the hospitals in the state, and it's helping to distribute them as well, which we're really grateful for, those, especially those smaller hospitals that don't have access to the supply chain.
Our supply chain are heroes, our unsung heroes, truthfully, in all of our systems.
Yep, thank you. All right, Susan, let's hear what's happening in the Spokane area.
Hi, thanks for giving me this opportunity. First of all, I just have to say how proud we are of the way our teams have responded to nearly 2 years of this pandemic. But I gotta tell you, we're tired and we're stretched too thin. I'm not sure the public totally understands how challenging things have become and the toll that that's taken on our workforce and all of us who are involved in healthcare. And we're gonna feel the effects of this pandemic for decades. Throughout the pandemic, we faced some ongoing major issues. We've continually had to reschedule essential surgeries, which impacts patients as surges have come and gone. Due to the staffing challenges, our emergency department wait times is much longer than we ever want it to be, and is very concerning for people who have emergencies and need the care. We still have more than 100 hospital beds between our two urban hospitals that are occupied by people who no longer need hospital care, but can't find care in the community, thus taking beds that are needed for other patients. We're doing everything we can to fill vacancies and improve working conditions, but it is a really tough situation out there. We've offered sign-on bonuses, shift bonuses, retention bonuses, and we're scheduling managers to actually come help take care of patients as much as we can to meet this demand. But the shortages we're experiencing are happening not just in Washington State, but all across the nation. And even with all these measures, there simply aren't enough staff to hire, even on a temporary basis. Unlike airlines that can cancel flights when they don't have enough staff, we can't cancel patients' heart attacks, strokes, cancers, and COVID cases when we're short-staffed. Our community still needs care. So currently, as you know, the legislature is considering a bill that's attempting to address this crisis. And we applaud that attempt to address this crisis. But these solutions won't address the underlying drivers of staff shortages. Bills mandate staffing requirements in hospitals through very specific nurse-patient ratios, which remove the flexibility in the ways services can be staffed. National staffing shortages would make compliance impossible with these new mandates. This legislation would make the nurse shortage worse and would exacerbate staffing shortages in other healthcare settings, including long-term care and outpatient surgery centers. This bill doesn't just affect hospitals. I think that's important for people to understand. Mandated staffing ratios are going to make it difficult for all sectors of healthcare, such as dialysis centers, outpatient surgery centers, long-term care, home health, and hospice would also need to hire significantly more nurses. There's simply not enough nurses in this state and country to meet our current demands, let alone the increased demand that this bill will bring. California implemented these ratios or similar ratios in 2004. And I can tell you it has not increased the recruitment or retention of nurses working in hospitals and not markedly improved the quality of patient care. House Bill 1886 and Senate Bill 5751 would prolong care delays and harm patients. Just last month, I mentioned the airlines. Airlines canceled thousands of flights due to staffing shortages. But hospitals can't close their ERs, their ICUs, and their critical care units. We have to be there for our patients. Instead, hospitals would be faced under this law with extremely difficult decisions that mirror how we're operating in the crisis today, which means postponing necessary care, long wait times, and postponing necessary surgeries. Rigid hospital staffing mandates, regulatory fines, and increased legal jeopardy don't create more staff. Only ending the pandemic and a significant investment in the healthcare workforce education and pipeline development will ease these workforce shortages. What we need from our legislators is to support solutions for growth and build the healthcare workforce of tomorrow, not mandates that are going to compromise our capacity to be able to take care of patients today. Thank you so much for hearing it. I am so proud of the work that we've done, and I thank you for the opportunity to share our status and where we're headed. Thank you.
Thank you, Susan. Really appreciate that. And last but not least, let's hear from Brenda for a rural perspective. And Ryan, there's someone in the waiting room too.
Hi, and I'm sorry, everybody. I can't get my webcam to work. I've been having challenges with technology. Not sure if it'll work or not, but it's this. Number one, I want to appreciate all the tertiary hospitals that have taken our patients. We're a critical access hospital. We have one general surgeon, that's it. So we don't have any specialists at all. And we have done the best we could when you can't take someone, because we completely understand. And I have pushed the nurses a bit. Had to, because helping them understand that they, just because we're staffed a certain number and we have one more patient, and I keep on telling them, unless that patient needs specialty care or is critical, don't call. Do not call the tertiary hospitals. They're inundated. So we're trying to do the best we can for all of you and make sure that the only patients that we need your help with are the ones that are critical. Right now in Pacific County, our county has just told us that they can't follow all the patients, all the community that are COVID positive. They're saying give out flyers when you can, but they will not, they do not have the staff in order to make sure that the patients are cared for, and that they're following quarantine, which is very frustrating, but it is what it is. So just to talk about the bill just a little bit, I am concerned because after talking to some of my nurses that used to work in California, we will have problems here. We are the only hospital on the peninsula. And if there are ratios in our emergency department, that means what do we do with those patients? Either we get fined or we take the patient, or we ask the patients to go somewhere else. Where is somewhere else? Somewhere else is 30 minutes away. And I can't see my nurses or my doctors doing that. They won't. We'll just have to be fined. So it's tough out there. We don't have enough staff. We're paying quite a bit of money for a couple agency nurses, and my managers are working the floor. They have to in order to ensure safe patient care, which means other things aren't getting done, or I take them on as well. So it is tough out there. But again, I just want to appreciate all the tertiary hospitals and the WMCC for helping us care for our really sick patients. Thank you.
Thanks so much, Brenda. All right, now to the questions. This is for Dr. Mint. The question is, did the reporter hear correctly that your Auburn facility is at 170% capacity? And would you please describe what that looks like now in terms of managing care?
Yeah. Sorry, can you hear me now?
Absolutely.
Sorry, I got a little thing that said unmute myself. So no, great question. Yes, you heard correctly. And luckily that's plateaued off. What does that look like? That looks like a lot of our surgical areas are not being used for surgeries and have been converted into areas that we care for patients, and many of our surgical staff are helping to take care of sick patients in our hospitals. Our EDs also have been backed up quite a bit because of this, but we have the advantage of having several healthcare facilities in the area, again, working with Mark and his teams in regards to better distributing the newer patients as they come in through EDs and others through our other healthcare facilities to level load. But South King County, as I mentioned, really has been a real epicenter. UW Valley and other healthcare system facilities in this area, and our VM Franciscan colleagues also are experiencing similar surges there. I think another part of the question as I'm reading it is in regards to refrigerated trailers. What I'll say is that the mortality rate overall, even though it is increasing as a state, still remains lower than that of other surges. The refrigerating units are really meant to just be a way to help to manage, as the real capacity challenges are actually in our mortuaries, where many of their staff have gone out ill, and they just haven't been able to take the patients from not just ours but other healthcare facilities. So we've had these units in place actually well before Omicron, and we're using them to respectfully continue to care for our patients while our mortuaries and other sites are able to then take these patients in areas, but it's not because of the current surge that we're using this capability.
Thank you, Dr. Mint. Okay, a question for maybe me or Mark or Susan. Are any of the Spokane hospitals part of the guaranteed acceptance protocols? Yes, they are. So we have both Sacred Heart and Deaconess are in the guaranteed acceptance protocol. And how much effect will that have on current operations? I think the answer to that is we don't really know. Susan or Mark, feel free to comment, but we don't know how many patients are going to be in this rotation. As Mark said, it's only been 2 so far. we hope that we're hitting the peak and we're going to be going down. So maybe we could even close it down soon, but we just don't know. Mark or Susan, any other comments you'd make?
I just very quickly, I suppose, address some of that. The process that we're going through is of all the requests that we get, anything that sort of rises to that level of needing immediate placement due to critical illness, whether that be critical procedure, critical medical management, the patient is, has, whether that, again, vital signs that may show some indication that they need immediate attention, whatever that sort of trigger is that we come across, we will immediately place those patients utilizing this protocol. And I would say all of the large hospital, the resource facilities in Washington State are participating in this throughout the state, both sides of the state, including and Central Washington. At this point in time, it's true for the last couple of weeks, this is roughly 2 to 3 patients in a 24-hour period that sort of meet this criteria. So it's not a large volume right now. But again, what the impact moving forward, what that looks like is really difficult to tell. The hope being that we will start to see a plateau in the COVID numbers, that we will start through some of the strategies that are being employed by all of our facilities with census management, through some of the support that has come from the state regarding support from National Guard, from state contracting agencies providing staffing resources, as well as what we hope to be some strategies to move some of the patients that are in hospitals that no longer meet acute care criteria. We will overall be able to decrease the overall census and create some capacity, so we don't need to continue this moving forward, or that capacity will increase again. But at this point in time, it's roughly 2 to 3 in a 24-hour period that are going to be placed statewide in some facility.
Thanks,
Cassie, sorry, I just want to maybe add to Mark's comments there. Multicare, we also, like our Providence colleagues, have hospitals on both sides of the state. And, one of the remarkable parts as an ID epidemiologist is just the asymmetry in how we see the different regions and different counties throughout Washington State sort of rising and going down. The Omicron definitely hit Western Washington much harder, much more quickly. We're seeing a slower rise, but a continued rise in cases in the inland Northwest. But the good news about, again, a statewide approach to level loading is that it offers then that patients can move back and forth between regions. And again, it's not just for Omicron. We've been doing this throughout the pandemic. When Idaho was having a significant surge earlier, our hospitals were able to help adjust and adapt patients throughout the state. So again, just emphasizing the importance of a statewide approach and a macro regional approach to patient placement to continue to allow those sickest patients to get the care that they need.
Thank you. Great point. So I'm going to follow up from that comment for either you or Susan. Do you have any projections showing when COVID hospitalizations will peak in the Spokane area or in Eastern Washington? These are some serious, like, cloudy crystal balls we possess, I will say.
This is a cloudy crystal ball. I would, based on kind of what we're seeing, and I certainly would welcome the perspective of Dr. Minnick too, because what we're seeing is it's still heading up. Much, if we compare it to what happened on the west side, which many times the east side will mirror, we anticipate 2 to 4 weeks, probably closer to 2 weeks to hit our peak, and then we should start seeing some stabilization for this. That's kind of what we're thinking now based on the projections that we're seeing.
Susan, spoken like a true epidemiologist. I think you're now an official, and many of us are official epidemiologists now, but I don't have anything to add. I think that range is really what we're anticipating. And I do anticipate that unlike what we saw in South Africa, which is kind of a rapid sort of a monophasic rise and fall, unfortunately, because of the way that the United States is not just sort of one unifocal country, it's a lot of different regions, we may see a little bit longer of a tail than some of the other countries have seen with this. And that's, consistent with what the IHME and other modeling groups are seeing. So anticipate that there may be a longer tail with a little bit of hectic, sort of up and downs as we go through this crisis. COVID-19 never ceases to surprise us sometimes in what we can predict, and humbles the longest serving epidemiologist among us.
I find that a disappointing answer, Dr. Mint. I would like that to not be the case. All right, questions about our staffing situation. So how many hospitals are at crisis staffing standards at this point statewide? I don't know that I think there's any hospitals that are not at some form of crisis staffing. Mark, is that your sense as well when you're talking to hospitals? Not, and it's just different. I'll be really clear. We're not talking about crisis standards of care and crisis staffing are two very different things. So no one is at crisis standards of care. That's a statewide declaration. Crisis staffing is essentially when you're staffing in ways that are not your desired and typical patterns of staffing. So Mark, maybe you could give us your perspective from talking about.
I think if we think about it on the continuum of conventional contingency and crisis staffing, and I couldn't agree more. What Cassie's describing regarding staffing and standards of care is extremely important to distinguish those two. There are no hospitals, there's no centers that are involved in crisis standards of care right now. There have been instances, likely in multiple facilities across the state, that have entered in and out of crisis staffing models for periods of time. How long those periods of time last can vary depending on the overall impact of those individual facilities. But largely that impacts things obviously things like staffing ratios. Certain strategies may be employed to utilize additional workers in clinical areas that previously hadn't been utilized. To my knowledge, the vast majority of the hospitals at this point in time would probably be reporting that they're in contingent staffing models for the overall majority of their time. But I don't have overall statistics about who is exactly operating in at what level, for instance, currently or today.
Anybody else want to comment about that?
Only comment that our commitment is to try to move down that spectrum of care. And again, part of the level loading is really to do that. We're seeing post-holiday that there were more staff that were out, probably because of the travel and some of the gatherings and those things. That seems to be stabilizing out a little bit also, which has been very helpful for our staffing. So we're only using crisis levels of staffing only in very targeted areas where we need to continue to have those folks coming back to continue to deliver care for our patients and communities, and again for especially all those conditions that require urgent emergent care. So we're trying to move as quickly as we can back to contingency and ultimately to conventional as quickly as we can, and only targeted use of the CDC levels that have been described of crisis staffing levels.
And I also just want to be clear that these changes to staffing patterns in hospitals, which we don't like, we want to be staffing based on our staffing plans, would not be possible under the ratios bill that the legislature is considering. The other option is you go on divert, which means what divert is. Divert is one of those words that masks something that's terrible. It sounds okay, like divert sounds like, oh, you're just going to go someplace else. But divert often means you can't find any place to go. Because if you've got multiple hospitals on divert, which means they won't accept patients into their ER, and this is the ambulances circling in Los Angeles, you just got no place to go. People, dying in the ambulance, they can't get into a hospital. So we, as Dr. Mint said, all hospitals are working very hard to get out of contingency or crisis staffing as quickly as they can. So Dr. Mint, there was a question which you touched on about the, and I don't believe that you're the only ones using this. How is it working to be bringing back some staff who've tested positive for COVID, and can you describe the things you're doing to protect patients?
Yeah, absolutely. We're doing several things to protect patients when we are bringing in back staff who've tested COVID positive. And first of all is just to make sure that they are improving symptoms, afebrile, not having any fever with any kind of medications, and ready to come back to work. And there are folks, especially folks who are vaccinated, who have relatively mild cases who meet that criteria. But we're very cautious about that our staff, as they come back, are able to carry on their functions, feel good, feel well enough to come back and care for patients safely. Two, we're really working hard on protecting them with what I mentioned earlier, source control, and we're following CDC guidance in regards to the highest quality masks that we can use. We are using N95 masks now for those who are coming in earlier because of the tighter fit that they have around folks' faces, and exploring use of other tools like KN95s to protect our staff in that area. And then third, we also are trying to assign staff that are coming back earlier than day number 10, which then we feel that there's minimum risk of any infections. But if they're coming back between day 5 and 10, which the CDC guidance in regards to contingency and crisis allows, then we're also trying to make sure that their assignments are either to patients who are COVID positive and or places where they would put any potential patient that has risk of immunocompromise, I think I read in the question, at risk by the choice of assignment of these critical workers who are coming back.
Thank you. Okay, another question about the staffing bill. The New York plan to put billions into healthcare worker pay is something that we support, and why hospitals are not already paying these higher wages to attract and retain workers. And I think many hospitals have increased wages or added bonuses or retention bonuses. It is also important to know that healthcare, the way healthcare is funded, is largely government funded, and both Medicare and Medicaid already pay hospitals well below the cost of care. Labor is our most expensive, the most expensive thing that happens in a hospital. And so when the revenue coming in from the government doesn't cover it, that's a big challenge. That's why this New York is putting $10 billion into this. This is a huge investment. So that's really that's the scale of what is required. If there are not enough healthcare, anyone else want to comment about that? About the payments to staff or things you're doing now to increase pay or bonuses for staff?
I can, if I switch hats for a brief moment.
Sure.
I'm also an administrator at Harborview Medical Center, which is a portion of UW Medicine. I think this is something that I would say universally healthcare hospital systems recognize as our primary need in staff retention and recruitment ability. It is ultimately much cheaper for us to do things like retention bonus with whatever we can offer, right? Education opportunities, things that people are seeking, in their careers that would make it appealing for them to join sort of the healthcare team within one of our hospitals, or stay within one of our hospitals rather than look for a position that may be higher paying but doesn't offer as much opportunity. We're doing whatever we can to make ourselves as appealing as possible. We really need workers in healthcare, and whether that be direct patient care positions, any number of other sort of supporting opportunities, including things like lab, things like our X-ray, our X-ray technicians, our respiratory therapists in general. All of these positions are extremely important to us, and we are not only actively providing things like retention bonuses, but also asking the tier, what is it that we can do to keep you around? Because this is for us critical to maintaining our operations. We simply can't afford to have our team members leave their positions. Whatever we can do to kind of keep them happy in their positions is what we're going to actively pursue.
Thank you. Anybody else want to comment? Susan?
Yeah, I'd love to add to that. Mark, you couldn't be more right. It is, yes, we absolutely have to take care of our workforce at all levels, nurses, all the way across the healthcare system. And that is absolutely looking at salaries. And as I mentioned before, bonuses, those things have been put in place. And we need to continue to look at them and see where's the next step. But it is more than that. It also is about educational opportunities and a pipeline of healthcare workers that can meet the needs. We have two factors going on. We do have a baby boomers. I have been throughout most of my latter career that the nursing shortage was coming. Our baby boomers are retiring. That is a piece of what the folks leaving the healthcare system is about, is natural retirements. In that, there's been some statistics that over Washington State has a 6,000 nurse plus deficit. It takes 2 to 4 years to grow a nurse, to educate a nurse through our university settings. So it's not going to be a short-term fix. We can offer, more and keep looking at this, and we'll get some headway. The long-term solution is looking at the pipeline for both nursing and other healthcare careers to invest in that, to stabilize this workforce, not just for the next 2 years, but for the next 20 years. And that's going to take everybody working together at all levels of the healthcare systems and our government, all working together for the same goal.
I'll only add just one more quick comment, completely agreeing with the prior panelists. The other side of things is that even prior to COVID, U.S. healthcare, I'm not talking about just Washington State now, U.S. healthcare didn't do as good of a job as we would like in caring for our communities in regards to health and wellness. And so part of what we're talking about here is not just, the staffing in the traditional ways that we've cared for patients, but also looking forward in regards to how, and COVID really called this out, on how we can work together in partnerships with community agencies and others, and think differently about both physician shortages, nursing shortages, and as Mark mentioned, many, many other health professional shortages that we're going to experience. And how can we think differently about our healthcare delivery model to make it more effective and more efficient, to continue to serve the communities, both around COVID and then in a post, hopefully in a post-COVID care environment. It's just so important from that population health, public health partnership to continue to get out vaccines for our kids and screenings and all of those things that we need to do.
And the second part of the question is, how quickly will the educational investments that we're asking for help? And this is that saying of the second best time to do something is today. We've been asking the legislature for a long time to put more investments into our state's healthcare workforce training programs. Our nurse training programs turn away hundreds of qualified applicants every year. So it will take a bit of time, but now's the time. So I think there's a lot of commitment from the hospitals to create clinical training slots for these folks. We want to see more simulation labs. We want to accelerate the nursing program. So I think it's let's do it. Let's make sure we've got the folks to fill in. I missed one question. Last question. I think that if I didn't get your question, please let me know. I think I've gotten them all except for the question about children developing diabetes following COVID. What percentage of children are you seeing, or any other way you can quantify that? And then there's a second unrelated part of the question, which is can anyone offer specifics of what jobs National Guard are taking on? I think they're both at Tacoma General and at Harborview. So maybe both of you. Susan, are they at Sacred Heart as well? Oh, all three of you are National Guard. So maybe all of you could say what the National Guard's doing. And we're very grateful to the governor and the general of the National Guard for mobilizing to support our hospitals. So huge thanks to them.
I'll just answer the first question really quickly. We don't have great data that is contextual that I could share right now in regards to ARPS. That has been an observation. I will put in the chat box the MMWR article, and we're continuing to work with the National Guard. They are coming on site, and we'll be working with their coordinators. But the ultimate goal is to make sure that, again, the ED is ready and able to take care of those patients who are coming in with acute conditions, and our hospitals are able to take those patients when appropriate from the emergency department. So more to come on that, but that's the level of coordination we're doing right now with the National Guard. So I'll hand over to Mark and Susan.
So we are so excited. Our National Guard Guard staff arrives Friday, and we could not be more excited to work with them. Has been outstanding in discussions with us about what roles and how to best support, and it's truly a collaborative approach. It's absolutely helpful in every way. These are non-clinical staff, but there's a lot of non-clinical work that goes on in the ER, transporting patients to and from the radiology areas, transporting them up to departments, helping to room patients. Just those simple tasks give a person who is a clinical person time now to go take care of patients. Helping to manage the waiting room just to make sure patients don't feel abandoned and lost, that somebody's saying, yes, we're coming in, and we're saying, you're still on the list, we are going to see you. And just those reassurances of the Guard. We have not been fully specific yet. We've not fully figured out, but we have not clarified all the roles. But I can tell you we're very grateful for them to be here and looking forward to solidifying this process as we get a little more context with the liaison and work with them.
And from Harborview's perspective, I also can't thank enough, the governor, the secretary of health, everybody that's been involved in the ability to bring the Guard to support our staffing. We are utilizing the staff, and also with us, they will be on site starting tomorrow. We will be going to utilize them. We have a on-campus testing site that has been used in two primary areas. One is for the patients, or for the staff members and their family members who are potentially, whether they be starting to develop symptoms or potentially exposed, need to get tested to ensure that they're safe to work or safe to return to work. And so that staffing, testing site has been there. We also utilize it in testing of some of the homeless population in order for them to be able to get shelter spaces in the community for those that require testing prior to shelters. We have had to staff that with our staff to support that function, and so having the Guard on site will, I think the primary impact is that we will be able to utilize the staff that we have deployed to that operation. We'll be able to have them return to inpatient care, which will be amazing for us. We're very much looking forward to that. I think also, in all honesty, and to Susan's point, this has been really great to work with them, and just to have them on site. I think everybody is really encouraged by the kind of the show of support and and just the emotional component of this, where staff will feel just supported by the state, recognized for their hard work, and hopefully we'll be able to see that there is a significant amount of concern for them to be able to do the work that they need to do in overall care. And we're going to support you with this ongoing operation that really we didn't intend to have happen, but the pandemic has kind of forced us to have in place for a very, very necessary operation. So they again will start tomorrow, and can't thank everybody involved enough. It will be a much welcome support for our staffing.
Thank you. That's a great note to end on. I think that, Mark, what you pointed out, that kind of sense of help is on the way, is a huge psychological boost to all the staff in our hospitals. So that's nice to end on a positive note. And so just again, to urge our partners in the media, please continue to have people, wear a better mask, keep your distance, get your vaccine, get your booster. I think Dr. Mint described about the level of deaths and the vaccination rates is just shocking. And, every time I look at the death numbers, I just feel heartbreak about those people whose children and siblings and friends and parents and, are left behind, just how tragic that is. So really hope that people will do all they can to protect themselves and their communities. thanks so much for joining us, and we will sadly probably talk to you again next week. We keep thinking maybe we could not do these every week, but it seems there's still so much action happening. I think we probably will be back with you next week. Take care. I think we're gonna move to Tuesday. Is that right, Beth?
That is correct. We'll be on for Tuesday, the 25th at 10 a.m.
We've had a conflict with the Seattle Public we're trying to, all the Seattle King County Public Health, Washington State Department of Health, and WISH are all trying to kind of space out their media briefings. So I think we're taking the Tuesday slot going forward. All right, thanks a lot, and thanks to our panelists so much for joining us. Take care.